All right, so welcome to Rehabilitation for the Amputee. My name is Paula, like I just said. I've been a therapist for over 30 years, almost 30 years, I'm going to be 30 in June, and have done most of my clinical work within the geriatric population, including 12, give or take, years here. So have seen my share of amputations and thought that it would be a good review for us to go through kind of what we do, because sometimes in school we don't learn exactly what happens in the clinic and what actually takes place. Dr. Peterson, like I said earlier, is the main physician who does our amputations here. He's one of the main vascular surgeons. Brian and Gary, I believe, both do them. But the care and dressings of the amputated site vary. Various doctors have different ideas, and again, we don't use like kiwis. If you know what a kiwi is, it's the compression and support of our amputations, the AKs and the BKs. We don't use those here. So if you learned about that in school, it's great, but some facilities don't use them all the time. Zimmer splints, I've seen Zimmer splints used here to protect the amputated site, and that's okay, but again, typically we have issues with when can we take it off? Can we do flexion of that BK even in the Zimmer splint? Does he want it completely straight? So those kinds of things are, we need to contact Leslie, who is with Dr. Peterson's office, and she's been a very good contact for me in dealing with those patients. The other thing that Dr. Peterson and Leslie have allowed me to do is the one-ply light tuba grip on his amputated sites. So the idea being that compression is good, but too much compression can retard healing, and especially since he does a lot of our patients have peripheral vascular disease and diabetes, we don't want that heavy compression on there. And yet when we do an ACE wrap or leave it open to air, you have other complications with pain and things like that, and edema management is poor. So he's allowed us to use one ply of light tuba grip. So if you look on, there's actually a grid, and I know Acute Rehab has a grid that says low compression, medium compression, high compression. Measure your patient, use the low compression, one ply only, and then what I typically do is put a rubber band at the end and slide it on real careful, okay, over the dressing. Skin checks. When you have your new patient, you're going to teach them to inspect their residual limb and also inspect their sound leg. Again, most of our patients have predisposing medical conditions, and very few are actually traumatic amputations. So therefore, you're looking for bruising or skin tears or anything on the sound leg that might impede their ability to improve and to get a prosthesis for their amputated leg. Teach patient the use of a mirror. I know OTs start with this pretty early. They use a long-handled mirror, inspecting the residual limb, and then again inspecting their sound leg as well. Educate the patient and the caregivers. So if they're going home and they can't, I can't bend over, I can't see the end of it, teach their caregiver. They need to be able to look at the limb and inspect it and know that something's wrong or something's right. Always notify your nurse of any changes. And really key is not to use any lotions on that residual limb, and also wear proper footwear on the sound leg, okay? So hopping or standing on that sound leg when a diabetic with a grippy sock, probably not the most optimal scenario. So you want to make sure that they're getting that, using that good footwear. Also, once they're past the point of only using that one ply of tuba grip, that's when we can go with the shrinker sock then. Pain control. Phantom limb sensation is common. 80%, this is one of your test questions, 80% of all patients with an amputation have some type of phantom limb sensation. It's usually painless and doesn't interfere. But we need to teach our patients those desensitization techniques. Make sure that you're teaching them tapping, rubbing, massaging gently on top of the bandage on that residual limb to get those nerve endings to calm down and behave a little bit better. It's really important to do that, and again, it gets the patient more familiar with their new limb. Because again, they're going to have a grief period when their limb is gone. So a lot of patients, some patients might say, I don't want to look at it. Some patients might say, I can't touch it. I can't even. They need to start doing that. So gently, gradually improve that. Yes, ma'am.
Like right away, like in acute care, like even if they're post-op day 2, or is there a certain amount of time you want to wait?
And again, even if you're just laying their hand on it, just kind of touching the end, you're not slapping it.
Right.
Yeah, but just getting them used to feeling it. How does that feel? And that does help, that desensitization, even that gentle touching does help that soon after. Absolutely. Good question. And then the phantom limb sensation and or pain, 6 months post-op can take that long. Positioning in the wheelchair. So here is one of the things that we really need to go over today that I've kind of focused on is positioning not only in the wheelchair but also in the bed. So I'm going to go over kind of in the bed first and then the wheelchair. So big thing, never put any pillows underneath your below the knee amputations. Never put any pillows underneath the AK either. Because again, we're looking at managing that limb in preparation for their prosthesis. So you want to make sure that their hip flexors are well stretched out and their hamstrings don't get tight. Sorry, brain fart. Hamstrings don't get tight, so you don't want to put pillows underneath there. If they lie on their side, you can certainly prop their amputated limb up on pillows and side lying. That's a very good position for them. Also, making sure that anything is not impeding the sound leg either, because remember, if they're on their back, laying flat, put a pillow up, float their heels a little bit. In the wheelchair, what's important? Safety, 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 fall prevention. So, amputee board, this one is for the BK. There's also a board that can be put under an AK if they have a longer AK. Anti-tippers on that wheelchair so they don't flip back. Make sure that wheelchair is proper width, because if you've got a tiny little lady in a 24-inch chair, because that's all you had, she's not going to be in that chair properly and her limb's not going to be supported on that BK board either. So make sure you get the proper size wheelchair, even during their hospital stay. Anti-tippers, and issue them a reacher straight off and teach them that bending forward in the wheelchair is a bad idea. We've had a couple incidents where patients have tipped forward and the wheelchair ends up on top of them because they don't have the quickness, they can't get their sound leg off of the chair and they end up on their, floor. Yeah, bad idea. So reacher, and teach them to reach for things out to the sides instead of frontwards in front of them. Okay? Those are just some good thoughts. Removable armrest. Get your patient a drop arm commode in their room as well, because we're going to be doing all those sliding board transfers. Oh, sorry. I skipped it. This is the one with the AK. Let me see if I can go back. Hang on. There we go. So this is the amputee board. This comes, actually, I just ordered a wheelchair for a patient to take home yesterday. It's a spitting image of what it does. It clamps onto the chair instead of the leg rest. So you don't put the leg rest on, and it slides out, and you can lift it up and take it away. So they're kind of difficult sometimes to get put onto your chair, but once you get it on right, you do have to tighten it up every once in a while. I will tell you it takes an Allen wrench, and these they do with people putting pressure through them, they do tend to sag, so you can reposition that and tighten those screws up a little bit. The AK, this is a picture of one, we don't actually own this, but if they have a longer AK and need that support in the wheelchair, this padded wooden sliding suspension will support the AK in the wheelchair, all right? Does not provide very much support or pressure relief on the sacrum, but it would support that AK. Positioning of the bed, I kind of backed up on that. So again, no pillows, no pillows, no pillows, no pillows. And really watch those hip and knee flexion contractures. Comprehensive rehab. Why do they need comprehensive rehab? Because we're here. PT, transfers, wheelchair assessment, safety, OT, self-care. We are the professionals that will get these people home and be able to allow them to function in a normal environment with their new diagnosis. TR, we have an excellent TR here. Her name is Jerry, if you all haven't met her. She's over there. So she provides our patients with this In Stride booklet and also a mentor program. So it's all things about enhancing your success as a lower limb prosthetic candidate. Preventing secondary complications. This is just what's in there today. Improving your balance to prevent falls. Overcoming emotional barriers that you might encounter. There's a whole rehab program pamphlet. Different organizations. She can hook up our patients with all the organizations for support groups and paraquad and whatnot so that they can meet up with people who have like diagnosis. She goes through what is phantom pain, things about personal care, nutrition, and diabetes. So Jerry's a really good resource for us, and we'll set up the mentor program for anyone who's interested. And you typically get those orders straight up, or do we?
No, I'm an ambulance chaser.
Okay, so if you have a patient, you notice Jerry's not on their schedule, please call your doctor and give an order for it. Social work assists us with discharge planning, post-discharge services. Nursing pain control and wound assessment. Use your nurses, use your social workers as adjunct to your therapy. And then on the acute side, again, make sure that those case managers are providing appropriate discharge plans for your patients. As far as pain control and wound assessment, let the nurse know if there's any additional drainage, if that patient's having excessive pain that is changed. Because if you keep them in the loop, they can make that therapy session a lot easier to manage. We also use the mobility predictor, which determines the ability to ambulate with a prosthesis. And the FIM scores at discharge correlate to this, not the admission FIMs. Who knows what the K levels are? Anybody know what a K level is? Okay, we're going to go over that as well. What we can do, the mobility predictor kind of feeds into the K levels, and the mobility predictor actually determines the opportunity for the patient to get a prosthesis. There's been several cases where my patient couldn't tolerate a prosthesis. They were an above-the-knee amputation with severe diabetes, a pacemaker, shot rotator cuffs. It's not going to happen. So we counseled the patient, counseled the family, talked with social work, got them the equipment that they needed, and the patient went home, mod-I at a motorized wheelchair level with a ramp access. So depending on what your patient needs, that's where we need to go and what we need to pursue. It's somewhat difficult when your patient who used to be able to walk at Dierberg's now can't. And it's very, there's a grief process that goes along with that. So approaching that subject is very delicate at times, and sometimes you need to actually intervene with the family, and they're like, oh, you're going to get a prosthesis in a week or two and you'll be fine. Not so much. It's really not going to happen. So you need to give them realistic goals and assist them with making those realistic goals and good choices. The mobility predictor questionnaire actually has 20, 19, and I've got copies of this if anybody wants it. There are 21 different items, things like sitting balance, sitting forward in a chair, sitting reach, being able to reach forward, attempting to rise from a chair with and without arms. This is with and without a prosthesis. So obviously, if you can stand up without a prosthesis, you're probably going to be a pretty functional ambulator. Single limb stance, obviously, balance-wise, if you can stand on one foot and do things. I know OT has an issue a lot of times where you're standing and you're trying to brush your teeth. How are they going to hold on to the walker and brush their teeth at the same time or use two hands? So that's very important to have your patient do that. And again, it's just a predictor of what their ambulatory status would possibly be at discharge. The K levels, like I mentioned earlier, are used to determine the patient ability to use a prosthesis. Scoring is used not only by us to motivate our patients, but also by the insurance companies to determine what kind of prosthesis this patient will qualify for. So a K0 is no mobility. They do not have the ability or potential to ambulate or transfer with or without assistance. The prosthesis is not going to enhance the quality of life. That's my guy who I taught sliding board transfers and got him a power wheelchair. A K1 is very limited mobility. So this is your little old lady who can put on her prosthesis to transfer to the toilet because she can't get her wheelchair in the bathroom, but she's not going to be hopping around Deerbergs, walking around Deerbergs with it. So that's a K1. They can be a household ambulator within the home, but again, it's not going to be someone who can change their speeds or turn quickly, things like that. A K2 is your basic mobility. They have the ability to ambulate with low-level environmental barriers, stairs, uneven surfaces, and this is a limited community ambulator. Most of our patients usually fall into the K1 to K2 category because of all their comorbidities. However, once in a while we get one that really takes off. K3, basic to normal mobility. Amputee has the ability or potential to use a prosthesis and may even return to some vocational, therapeutic, or exercise activity that demands it beyond simple locomotion. I can think of Dan is our volunteer. He's an amputee. He's probably about a K3. And as a matter of fact, he told me last week that he actually has been bumped up a level because these are dynamic levels. They can change. He's been bumped up and then qualifies for a better foot, a better ankle, okay? K4, high activity, goes up to being an athlete. So the K levels are determined by us, the prosthetist, the physician, and again, insurance companies look at these things to determine what type of knee. Can you get the computerized knee? Can you get the better foot? Do you need the running leg? Things like that. So make sure that I've actually given these to my patients and the mobility predictor and told them this is what you can work on. These are things that they're going to be looking at. These are things that are going to qualify you for a better prosthesis and improve your quality of life. So transfers that we do, sliding boards. Make sure you're doing them to the right and to the left to prepare for toilet transfers. Even surfaces are best. Going uphill is hard. So when we're looking at things like getting the what their transfer needs are in their room, do they need a lower bed because their bed won't go low enough to be even with the wheelchair? So make sure, again, you're talking with nursing when they need a low bed so we can do the sliding board transfers. making sure you're going back and forth. And practice it with them in the room. It's so different. You guys know the beds versus the mats. It's like night and day. So when we say, oh, well, they're, mod I in the gym, yeah, well, they're mod to max in the bed because it's uphill and there's stuff all over and the locks on the beds don't work right. So make sure that you're doing them in the room and educating their staff to make sure that they're capable of doing it. And even I've had the CNAs, ask me to help them. And so how about you do it and I'll coach you, and that way when I'm out of here you can do this on your own, and that works out real well. Wheelchair assessment, there is a form available in PC. If you're going to need anything other than just a lightweight standard, if you're going to need a power wheelchair, you're going to need to fill out this wonderful 11-page form complete with ICD-10 codes. So those forms are available in PT, and Provider Plus is really good about helping fill those out. Those require the signature of a doctor and the patient and the therapist, because they're going to submit it to the insurance company. I'm kind of jumping around here, I apologize. I thought it was the better one. So we're going to go vehicle transfers. Make sure that when you're doing a car transfer that you actually do this a couple days out. It's really beneficial for your patient and their family members to feel comfortable doing this. So using the sliding board, I found that sedans, getting in a four-door sedan is so much easier than getting in like an Equinox or an Escape, especially for my shorter patients. So using the sliding board in the sedan is exponentially easier. For our taller patients, we just had a guy who did a stand pivot with a walker into an Escape, and he did fine. So either way, make sure that you're going through this before discharge. The other thing with discharge planning on these patients, make sure they have a ramp. Everybody who leaves here, 99% of our patients with amputations are going to be in a wheelchair primarily, because we only get a couple weeks. So they're not healed, we're not putting them in a prosthesis, they're not safe to hop upstairs. So be talking about getting a ramp with your patient from day one. Who can install it? Do you need me to hook you up? What can we do to get this happening? Or can someone bump you up in a wheelchair? So the other thing you need to know is the dimensions. An 18-inch wheelchair needs a 24-inch doorway. A 20-inch wheelchair needs a 26-inch doorway, because you have to add that width for the wheels and the brakes. So you need to make sure that that's in place before you discharge your patient. I'm going to go back here a couple seconds. Exercise. Yeah, we love exercises, don't we? All right, so good exercises for your amputation patient. Anything in extension, because when they sit, they're going to be sitting all day, they're going to be in flexion. So you want to do everything in extension. Standing, extension in the parallel bars if they can maintain weight bearing on the sound leg. Supine, prone. Make sure you're getting your patients prone if you can. Prone is actually extremely beneficial for those back extensors. You can see the middle one. And also to decrease any hip flexion contractures, propping a pillow up, and putting that AK limb in extension. So make sure you're giving these exercises to the patients. Patients, you'll be surprised what they'll do for you if you give them the handout. Here's your handout. Do this one for me tonight. Do it 10 times. You come in the next morning. I did 3 of them and I did 20 reps. They want to please you. They want to get better. They want to get home and get back to normal life. So give them the exercise. Don't be afraid to give them handouts. We have all these handouts here. Paper's not very expensive. Give them a couple copies. Oh, I lost it. My wife took it home. Great. Here's another one. Post it on their wall. make sure they're doing their exercises, because that's what's gonna get them ready for that prosthesis. One-legged bridging, sitting, knee extension, abduction, moving that leg away from the midline. Those are all very good exercises. Anything I missed? Anybody think of something they typically do? Okay, all right. Booty squeezes. Booty squeezes are good exercise. All right. Ambulation guidelines. Limit ambulation to less than 20 feet. Why do I say this? Number one, to keep that sound leg sound. If they have PVD or bad diabetes and have a sore on the bottom of their foot, that jarring, that hopping, if their arms aren't strong enough to let them land softly, can cause additional issues. I've actually experienced that sound leg had to be amputated because on down the road they just kept hopping and really trashed it out, for lack of a better description. Also, you're unable to get a wheelchair if they're ambulating a lot farther than that. Because again, they're gonna be in that wheelchair. Yes, they might be able to ambulate 50 or 75 feet with you and the gait belt and the wheelchair follow, but that's not exactly going to be functional at home. So they're gonna need that wheelchair, and if the insurance company's gonna say, if you're walking all that way, they don't need the wheelchair. So make sure you're watching your documentation and making sure that patient will be able to get that wheelchair, because that's what they're really gonna need primarily. Standing on the sound limb tends to encourage the poor center of gravity. When you are standing on one limb, you tend to you tend to sag on that side and kind of lean towards the other side to balance yourself out. So therefore, you're kind of defeating the purpose of standing up straight, and it's very difficult with someone who has a limb loss on one side to get them even. It takes a lot of practice. So rather than encouraging that dropped hip on that side, because obviously we're going to put them in a prosthesis and they're going, well, it's too long because I'm still here, and now you feel off center. So make sure you're trying to encourage them when you are doing standing activities to keep their hips level, and then, but again, don't do a lot of ambulation because it tends to throw that off. And again, can worsen the status of the sound line. Questions, anybody? So we're getting them to go home. Wheelchair width, make sure you're measuring all the doors, turning radius, the ability of the family to transport the chair. A lot of times, oh great, we'll get you a power wheelchair. It takes a specialized van to get that anywhere. Typically, Provider Plus, if I'm ordering a power wheelchair, will deliver it to the patient's house. But now you've confined them to their home, because if they only have a power wheelchair and they have a ramp but they can't get it anywhere past the driveway, you've kind of limited their mobility. And then items in the kitchen no higher than the counter, because if they'll be at their wheelchair level, if they're independent at home, if they're home alone for any period of time, they're not going to be able to stand up and get into their cabinet. All right. Questions? Did I forget anything? Anybody have any specific questions about treatment management?
I would add that we have a little accessibility questionnaire that the families can fill out, so we have that available to give the families, so we can start looking at accessibility. And Carolyn Havrock did a really good in-service a few years ago on care of the, wasn't it diabetic? And so there was those handouts are really good to give the patients that are amputees, because so many of them are from diabetes. So I would say we have those resources available too.
I'd also like to add that for those of you who aren't up on acute rehab, we do have an amputee support group here at the hospital. So you can always give them that information. They can go online and look up St. Anthony's amputee support group. We've got a great webpage. They can look at it. It gives a lot of links to other information also. And then join our club. You can get right online.
All right, thank you all for your.
Hey,